Oncology is an interesting ward because primarily my area was in the bone marrow transplant ward, so that's traditionally where people remain in hospital for extended periods of time whilst receiving their bone marrow transplant. They're exposed to horrific medications that can make them very, very unwell. They have to be in isolation for periods of time. Anything that comes into contact with them has to be sterile. The role of the occupational therapist in that type of environment is really that to kind of normalise their daily activities or daily life, make sure that they are still managing their self-care requirements, so whether it may be looking at equipment needs to ensure that, if they need to sit down in the shower, that they can safely do that, if they need grab rails to get on and off the toilet. As well as, I guess, trying to still create that normality in their life when they're faced with isolation. Can they read? Can they use an iPad? How can you still develop purpose and meaning in their life when, quite horrendous things are going on around them? So that adjustment, and it probably involves a lot of that mental health side, but that adjustment to their injury and to their treatment is optimal for them, and that they are as stable as possible throughout the treatment. There's often those limitations in the hospital environment. Certainly time is a massive pressure when you're in those acute environments. You have many, many patients that you have to see, and whilst you would love to have gotten in the car and actually seen the home environment just to check how many stairs there were, what side the grab rail was on, how are they managing their shower over bath, do they, are they grabbing onto something like a toilet roll to get off the toilet when clearly that's not going to be stable for them, all those types of things. Sometimes that wasn't possible, and you would look to then referring on to community resources, occupational therapists in the community, either private or government funded ones that were able to follow that up. So you are limited to that kind of snapshot of the acute hospital environment, and I guess as a clinician you learn to kind of cut off at that point, which is challenging because you often didn't get to see that progression of people. In my role now, particularly for my catastrophic injured people, if you're starting with them in week 1 and you get to see them through discharge and back to home, then there's nothing more fulfilling than that, because you get to see that whole injury spectrum, whereas when you are in that acute hospital environment, that's often the only environment that you see. So in some ways you get a little jaded because you know just to work from that to that period, and unfortunately you have to kind of refer on from there. But that's just the way that it works, and you get very used to working like that because there's a million other patients behind that one that you have to see. So.